Today, Dr. Nadine Aguilera has an interesting case of hepatosplenic T-cell lymphoma with an unusual phenotype. Dr. Aguilera is an associate professor of pathology at University of Virginia, and she's also the Hematopathology Fellowship Program Director and Division Director.
Today we're going to look at a spleen. This is a case of a 72-year-old male. He had abdominal pain and massive splenomegaly. The spleen was removed, and this is the architecture of the spleen. You can see on low power that there's still white pulp in the spleen, but the red pulp is enlarged and infiltrated by a cellular infiltrate. We're going to get closer, and you can see that they appear to be lymphocytes. A good part of the spleen was necrotic. And here is the area where it actually is viable next to the necrosis. So as we get closer, the lymphocytes are monotonous. They're sort of small to intermediate in size with abundant pale cytoplasm. So at this point, it was fairly obvious that we were dealing with lymphoid neoplasm. So we need to do immunohistochemistry to see what we're dealing with. First thing we look at is CD20. And here is a low power of CD20. You can see that the white pulp is positive, but those cells in the interfollicular areas are negative with CD20. Now we're going to do a T-cell stain, so CD3. And you can see at low power, CD3 is involving the entire area of the red pulp. You can see the white pulp looks fairly normal and is uninvolved with the CD3. So we're going to get closer to the CD3. It shows cytoplasmic staining and possibly some membrane staining. So we feel fairly strongly that we're dealing with a T-cell neoplasm in the spleen. So we'll go through the T-cell markers. CD2 also appears positive in these cells. You can see at low power, the white pulp is negative with the CD2, and CD2 is positive in the majority of cells in the red pulp. 7, also positive in these cells. CD5, and it's completely negative. In general, hepatosplenic T-cell lymphoma is almost uniformly characteristically CD5 negative. So because we may be dealing with that entity, we have a few more stains to look at. CD8, which appears positive in this case, and CD4, which is negative. Hepatosplenic T-cell lymphomas are generally TCR gamma delta phenotype. So we have TCR gamma immunohistochemistry, and in this case it was negative. So that kind of threw us off to some degree. So we did a TCR beta F1, which is our alpha beta T-cell immunohistochemistry, and it is positive. Hepatosplenic T-cell lymphomas generally are CD56 positive, and in this case, it was strongly CD56 positive. This type of lymphoma also tends to have cytotoxic T-cell markers, and here you see this is granzyme B, which is positive. You can see it's positive in this granular fashion, and that is very characteristic of a hepatosplenic T-cell lymphoma. The TCR expression of alpha beta was unusual, but the remainder of the markers is very characteristic of hepatosplenic T-cell lymphoma. CD57 was negative, so we're most likely not dealing with a large granular lymphocytic process. So this was interpreted as being a hepatosplenic T-cell lymphoma of the alpha beta phenotype, which is generally not seen in older individuals, but this particular case it was. So this is just a little bit out of the normal epidemiologic presentation that you usually see, but everything else fit perfectly for that. So it was called hepatosplenic T-cell lymphoma alpha beta type. We'll talk a little bit about hepatosplenic T-cell lymphoma. These generally peak in adolescents or young adults, which our patient is a little unusual because he's an older male. They commonly occur in chronically immune-suppressed patients, solid organ transplant or autoimmune disease, and also there's a peak in Crohn's disease as well. They usually are of the TCR gamma type, of gamma delta type of T cells, but in our particular case, we had an alpha beta TCR type. The alpha beta type is usually rare and are usually seen in younger females.